Hello. Good morning.
Morning. How you
I thought
going?
I was the only one. I was checking if I've got the date wrong. When I signed in, it was just me, and I was like, am I am I on the wrong date?
I think it's just you and I today.
Huh.
Um, so we're talking about toxicities, but quite individual toxicities. And we talked about like we made a list last session of the ones that you want to go through. Do you
hmm
remember any in particular that you really want to go through, given it's you and me?
I what did we talk about? We talked about said we'll do lilies in cats. Then the neuro we did think about tremors.
Yeah, we did tremorgenic toxins. We had lilies and grapes, like AKI, kind of.
Mm.
And I think Simone was most interested in that just because of the like kind of shift in the way that we kind of manage fluid therapy.
Yeah, yeah.
So we'll see if Simone comes, but we might cover that just in case she tunes in later. And then paracetamol, non-steroidals, and sulfonamides, like just to cover the idiosyncratic kind of reactions.
hmm I think any would be fine because sort of equal. I always look up if there is a case. I always look up just to see if I'm remembering things correctly or if there's anything new. So I'm usually like always looking up things. So
Good.
happy to talk
Yeah.
about anything.
Yeah, there's so many updates that come through. So yeah, I always look everything up.
Also, I don't trust my memory.
Also, yeah, absolutely. And every now and again I'm like, yeah, I'm sure I know how to do this, and I'm thinking of a completely wrong disease. Okay, well let's start with paracetamol then, just because that's the order that I kind of studied them in. Do you remember what the pathways of detoxification are? Like the different ways that the liver can detoxify or different cells throughout the body can detoxify
Like
different.
this, the glucuronidation.
Good, yeah.
Uh, the And sometimes, like what I do remember, sometimes it's the metabolite that's the problem. So not the
Yeah,
actual drug itself. And I think that's the case in paracetamol. It's not the actual drug, but the metabolite, which I can't remember the name, is the problem.
yeah, you're exactly right. Yeah. So
The
there's three
cycle.
different pathways that the body can get rid of toxins by. Number one is biotransformation. So like that's where the cytochrome P450 system converts it into a different form, usually
hmm
by hydrolysis, oxidation, or like reduction, maybe something else. But add something to it or take something away to make it a different structure, basically. So paracetamol does undergo biotransformation as one of the pathways. So by that cytochrome P450 system, and it's metabolized to NAPQI
Hmm.
is the acronym. The actual word is N-acetyl P-benzoquinoneamine. NAPQI. We'll refer to it as that. So that's one of the pathways. Why are cats? Well, what? So the other pathways are glucuronidation and glutathione conjugation. So that's where the toxin is bound to something else that makes it then easier to excrete. The conjugation is binding to a glutathione or glucuronic acid. Um, so what pathway typically out of those two would paracetamol be processed in humans and dogs?
It's, isn't it it is, I mean, in cats, it's a problem because they don't have the cytochrome P450. So I'm assuming that's the pathway.
They do actually. So cats have got the P450, they don't have glucuronidation.
Glucuronidation, okay.
Yeah, that's the one that they're missing. So of that, paracetamol can be processed three ways, basically. It can be go through the cytochrome P450 system, which makes that toxic metabolite, which then has to be conjugated to be excreted. So it gets biotransformed, and then the cats just don't have capacity to bind it to the glucuronic acid, whereas humans and dogs do. So cats can tolerate like a like factor of 10 less paracetamol than dogs and humans can.
Okay.
Because dogs and humans can glucuronidize it after it turns into that toxic metabolite. And then the other thing that cats sometimes do is add a sulfur group to it, but that's just because they've run out of other pathways, basically. And all of these pathways just have a capacity, and as soon as you kind of get a backlog behind, then it's going to start to go through other pathways to be processed. So if cats don't have good glucuronidation, there's going to be a bit of a backlog of the NAPQI
Hmm.
accumulating, because all of it's going through that P450 system.
Hmm.
So then what does the NAPQI do? What's the actual toxicity?
It causes, I think it causes like hepatocellular injury and death.
Yeah, absolutely. And what other cells are affected, particularly in cats?
Mm. Does it cause methemoglobinemia, I think?
Yeah, it
Or it
does.
can.
Yeah, yeah, exactly. And then there's another type of anemia that we see in cats specifically.
Heinz bodies, is that what
Yeah,
you're? Yeah.
excellent. Yeah. So we get methemoglobinemia and Heinz body anemia, so quite profound anemia as well as decreased oxygen carrying capacity. Shouldn't say carrying capacity, I should say that it releasing more.
What level of Heinz bodies should, like, this is not related just to toxicity, but because Heinz bodies, at what point should you be worried? Because some can be normal. So literature just says some, but what is some? Is it 5%? Is it 3%?
It's such a good question, and it's so non-specific because oxidant damage will, like, there's oxidant damage in the body all the time. So I've had cases where I might either, I don't know if this is like this cat's septic and it's got a Heinz body anemia. I'm not surprised at all
Mm.
because it's septic. But in that case, we kind of got to greater than 10% Heinz bodies, and the pathologist was like, hey, there's too many here. Like
Yeah.
something is going on. There's like a specific toxicity kind of thing. And that was more than like 10% of red cells. But I don't actually know where the cutoff is, like what's normal oxidant damage in our
Yeah.
population of sick patients.
Yeah. Yeah.
Yeah, the normal is not our normal for the animals that we're seeing.
Okay.
Yeah, don't know the answer to that. Sorry.
Well, that's okay. I just thought I couldn't find it. So I was like, oh, because I often wonder what is. Because sometimes you do see, but then it's like, is this really relevant? Is it just a red herring? Because you can
Another
get trapped
marker.
in.
Yeah. So why do you, this is more of an anemia chapter question, but why are cats so susceptible to hemoglobin damage with oxidant
Mm.
damage?
I know cats like they don't have a central pallor, but that shouldn't really.
No, it's actually
Mm.
the structure of the hemoglobin. So the hemoglobin is bound to sulfide, and in humans, I think they have 4 sulfide bonds.
Hmm.
And the more bonds you have, the more susceptible you are to breakage of the bonds, I believe. So cats have more bonds. I think they've got 8 sulfide bonds in their hemoglobin. So they're much more susceptible to oxidant damage in that it denatures their hemoglobin, and they get antibodies.
Oh, okay. Had never really thought about that. Good. Thank you. Thank you.
Yeah, that's all right. Um, so what happens physiologically when you've got hepatotoxicity and anemia? What are we going to see in our cases? What are they going to look like?
Like clinically.
What abnormalities are we going to see? Anemia.
I mean, anemia can literally do anything. So in terms of clinical exam or physical exam, sorry, you may see pallor, but in terms of clinical symptoms or signs, they can be weak, lethargic, they can be very non-specific. So I don't think there's anything specific. But on physical exam, you may see pallor,
Mm.
depending on how severe the liver damage is. You may or may not see icterus too.
Yeah, yeah, for sure. And because of the methemoglobinemia, sometimes we might see actually
And
brown.
red, yeah, that will have red, like your brown gums, not red.
Yeah. And it's tricky because they're brown because of the methemoglobin discoloration, but they're actually got cellular hypoxia because the methemoglobin is bound to the oxygen. It's not letting it go. So the cells are all getting deoxygenated. So you will get a degree of cyanosis as well. So it's not always like brown, like
Mm.
methemoglobin is brown. You will have a combination of both. Um, so biochemically, what sort of ALT to ALP kind of ratios would you expect? Which one's going to be higher?
Because it's a hepatocellular damage, I mean, not ideally, nothing is ideal, but ALT more likely to be elevated than ALP.
Yeah, absolutely. Yeah, so we should have the ALT much higher than ALP, usually above 5 times. It's a primary hepatotoxicity rather than cholestatic toxicity. So ALT will be quite high. Bilirubin's often high as well. So it's a little bit of a trap. So a lot of the in-house profiles that people do before they refer patients don't have bilirubin in them if they're just doing their like small profiles. So we often kind of look through and go, oh, the bilirubin wasn't elevated, but actually you've got to check the bilirubin was run because it's probably the easiest thing to monitor that improves real time with your kind of effective therapy. So it's good to get a baseline.
Yeah.
Um, so what sort of therapy can we use to decrease toxicity?
With this one, you can use the N-acetylcysteine.
Yeah.
I think from memory, I've done it in the past. You do a loading dose and then you do, I think, 6 more doses. This is the bit I have to look up. I think you do six followed by, like, I think 6 more doses. And so in 7 doses in total every 6 hours or something like that.
I wouldn't have a clue. That's definitely in the look it up territory. Why do we use N-acetylcysteine?
It's because you have hepatocellular damage, typically like glutathione, it's a
Mhm.
precursor, the N-acetylcysteine, so it'll help with the glutathione, which is essentially
Good.
reducing the oxidative injury to the liver.
Yeah. So we've got that toxic metabolite, NAPQI, which can't exit the liver. It just sits in there causing this toxicity until it's bound to a thiol group or glutathione. So once you've run out of glutathione, it's just sitting there causing toxicity. So if you add glutathione to the system, you increase capacity for the body to excrete the toxic metabolite. So that N-acetylcysteine is the best and strongest thiol donor that we can access. If you don't have IV N-acetylcysteine, what medications might you be able to use that's another thiol donor?
Is it SAMI? Is it?
It is. Yeah, perfect. Yeah.
SAMI, I know it for meat.
Milk.
What is for glutamine, right? No, glutathione.
Glutathione.
Yeah.
Yeah. Yeah,
I
exactly.
keep getting mixed up between glutamine and glutathione. They're two different things.
Two different things. We'll talk about glutamine and then neurotoxicity one.
Yeah, yeah. I always confuse the two in my head.
Yeah, glutathione. Yeah, the thione is because it's a thiol group, which is the
Mm.
bit that like binds and creates that I think it's water solubility they're going for so that it can be excreted. Um,
Mm.
yeah, anyway. Um, so you can use either of those two things, and acetylcysteine is much more effective. Obviously, these patients, a lot of them don't have a functioning gastrointestinal tract, and SAMe can't be delivered
Mm.
systemically to be oral. So it's not the best option, but definitely if that's all you've got, definitely use it. And I think an acetylcysteine is quite expensive, and I think there is a risk
Yeah.
of anaphylaxis with it or something. There's some risk.
Mm. Yeah, that's the
Mm.
way to look up. But it is, I do remember it is expensive, but it's like, it's something that if you have, there's also a toxicity. You have to see how much it's dose dependent. So you have to see the dose, whether it's the relevant dose, right?
I would always
To
check the
cause
dose.
the toxicity.
Yeah, my brain doesn't remember numbers.
Like mix per kg, you have to work out how much, but it's not too much. I think in cats, from memory, I think it's about 13 or 15 mix per kg. If you work out, that's enough to cause hepatocellular damage.
Oh yeah, for sure. Of the paracetamol.
Yeah, yeah,
Yeah. Whereas in dogs, typically we give 10 to 15 mg per kg. But the toxic dose is like 100 to 140 mg per kg.
yeah, yeah.
Yeah. Yeah, it was cats. Cats is like well within, like there's no therapeutic range for
Yeah.
cats. Good. What else would we give for specifically the methemoglobinemia?
Uh, I think ascorbic acid, but I don't know the mechanism.
Yeah, me
I just
neither.
read that. Like I've read that, but I don't know how it works.
Yeah. So vitamin C, right? Ascorbic
Mm.
acid. Yeah.
Yeah.
So they use vitamin C, like anecdotally in like snake bites and things as well. So I just found it interesting that it's got that application. But what I read in the brief reading was that it converts methemoglobin back to hemoglobin.
Mm.
And then the other thing that was on the list of treatment is actually cimetidine. Did you read that?
To be honest, I didn't really read this. So,
That's
what's
oh,
cimetidine?
I put
Huh.
you on today, but you're glad you're the only one here.
Why cimetidine? What would that do?
And so it actually decreases activity of the cytochrome P450 system. So it inhibits it. So you get less conversion of the paracetamol to the toxic metabolite. And it just buys you some time to get the glutathione system going. It's an interesting approach. And kind of, I think it's just a nice demonstration of how toxicity and detoxification works, because you can work on decreasing accumulation of the toxic metabolite, so decreasing biotransformation, and you can work on improving transformation into a non-toxic metabolite. So
Hmm.
you can work both ends of that. And then obviously actually supportive care for the toxicity. Cool. All right. Any other questions about paracetamol?
Hmm. No, not for toxicity, no.
Cool.
Do you, with the, because I mean, obviously, since the liver is involved, would you, is there a need to check coags, do you think? Or if we did
Oh,
check, because again, we're talking about cats and like cats, this is the bit I always get very this thing. Cats sometimes can, some cats can have that APTT elevation anyways because of the deficiency,
yeah.
factor twelve deficiency. So in scenarios like this, when you're checking, let's say,
Mm.
oh, this is good. Because if you're checking this, let's say, and, and your APTT is high, how do you know this is not, this cat is not like going into DIC versus this is just normal for this, like it's just it's just elevated? How do you tell
Basically,
that?
yeah, I reckon the PT is the telling factor. So if you're going to DIC, you're going to have it usually elevated fibrinogen, and usually they run that on the profile. If you're doing it in-house, you won't get that. But if the APTT is sky high and the PT is smack bang in the middle of normal, it's probably a genetic factor 12 deficiency, because the
Okay.
APTT will be off the scale. Whereas if you've got DIC, the APTT is almost just a more sensitive PT. So APTT goes up first, but PT follows it. They go
Yeah.
together.
Yeah.
So if the PT should be upper end of normal or above normal if it's DIC or a coagulopathy causing the abnormality.
Okay. Yeah. So look at the PT as well then, yeah.
For the PT as well, exactly. Yeah. Um, yeah, and or obviously acute liver failure is what we're dealing with here. In some cases, there's a lot of supportive measures that we need to have in place in the treatment, and I've only covered the detoxification side. Like, please don't just use this as a treatment protocol.
Mm-hmm. Yeah, because it'll depend on what else is there. Like if you have hypoglycemia, then you need to add glucose to your fluids
Yeah,
and things like that. Yeah.
very critical care. Yeah.
Would you
Um,
recommend checking like checking glucose every now and then, or once you start the treatment, do you
for
think it's
sure.
not necessary?
Oh no, I think it's necessary for sure. Yeah. Because the you've got when you see them, what you're seeing is the liver cells that they've lost. So you need to support them through to regenerating those liver cells, because their liver function, you can detoxify them and decrease further damage, but it's going to take time before those liver cells are recovered.
Hmm.
Um, Good. Okay, so the next one I've got on my list is non-steroidals, which we've probably covered to death. Everyone's pretty familiar with non-steroidal toxicities. Did you want to just whiz through it?
Yeah, we can talk about non-steroidal toxicity.
It's so common. I think it's a good one to really understand well because it's so common. So how do non-steroidals work?
Um, the COX, like they inhibit the the arachidonic acid is released from plasma membranes.
Yeah.
It sort of they inhibit the cyclogenase, which is the
Mhm.
enzyme in the production, I think.
Yeah.
That's
Hmm.
what I remember.
Hmm. Excellent.
So I also remember like they in school we were taught COX-1 and COX-2, but then I also remember being taught that it's in the body, it's not as because there are some products are marketed as COX-2,
Mm.
uh, like they're pro COX-2, but it's not in the body, it's not so
Yeah.
distinguished. So it's like a combination.
Exactly. So essentially, the arachidonic acid pathway is the pathway that is required to make prostaglandins.
Hmm.
And there are inflammatory prostaglandins, like the ones that are produced with osteoarthritis, which is usually what we're using non-steroidals for. And there's protective, like essential prostaglandins that we need throughout the body. So typically, COX-1 does the protective prostaglandins. COX-2, traditionally, this is sort of what we were taught. COX-2 are the inflammatory prostaglandins. So if you're using non-steroidal, the drug companies who produce COX-2 specific ones will tell you that you should use a specific one because you want to conserve the like body protective prostaglandin production. In practice, we know that for COX-2 and selective inhibitors will cause toxicity because of the suppression of COX-1 as well, or the protective prostaglandins as well. So we do see toxicity with both, but it is more common with non-selective COX inhibitors. So what do we know? We won't talk about the inflammatory prostaglandins, but what do the protective prostaglandins, where do they have their biggest role?
And the GI tract, I think.
Oh, mm-hmm. What's their job there?
What's their job there? Hmm. They The protective ones, they aid in like healing gastric ulcers, which is why you get like one of the side effects of uh, NSAID toxicity is, you can get ulcers.
Yeah, exactly. So their job is to increase mucus and bicarb production. So that sort of layer that just sits on the surface of the stomach, protecting it from the gastric acidity, is decreased when you've got less prostaglandins. So there's less protection. You also get an increase in gastric acid when there's no prostaglandins there or decreased prostaglandins there. And you get decreased blood flow. So as soon as you get a little erosion, it can turn into an ulcer because we've got less healing capacity because there's less blood flow to the mucosa. So we get ulcer formation, as you said, as a result of that. How might they present?
Specific this toxicity or GI ulcers?
Let's say just GI ulceration.
I mean, typically they can have hemoptysis or melena.
Mm-hmm. Sorry, I shook a big
Right?
gulp.
Again, non-specific, like they can have hyperexia, lethargy.
Mm.
Yeah, you would be more inclined to thinking if there's GI perforation, or not perforation, sorry, ulceration, if they have
Mm.
melena or hemoptysis, like that should be one of your differentials.
Yeah. Um, and perforation sometimes, septic abdomens. Um, Sometimes, particularly cats, I don't know how they do it. I had a cat once that just had this abdomen full of gas and barely any free fluid. And I was ultrasounding it, just going, I can't see anything. It's like looking through a cloud. Like, this is so annoying. Is it clipped short enough? And blah, blah, blah. And it had perforated gastric ulcer. And it had just filled its abdomen up with gas. No gastrointestinal signs whatsoever.
Wow.
So yeah, I don't know how that happened, but went to surgery and it was definitely a perforated ulcer. Um, so yeah, they can present like acute abdomen with no
Hmm.
gastrointestinal signs. And I think the lean is so hard to call. like particularly you prep owners, like you sort of prescribe non-steroidals and you say, if you see that stools become darker, like bring them in, and then they like send you photos of like the poos with the darker coating on the outside and they're still light brown in the middle and blah, blah, blah. Like I think owners are bad at interpreting it and
Yeah,
therefore we don't trust their history so much. So
yeah.
there's some,
But then you do a rectal, like when you have a sick animal, like you do a rectal,
yes.
and if you're seeing melena yourself, then there is melena.
Yeah,
Whereas
but
owner sending you pictures, I mean, my first thing always is how long has this poo sat in the sun? Because sun will
yes,
coat
yeah,
black.
exactly. That goes brown, goes dark. Yeah. Um, yeah, sometimes the melena can be intermittent though. That's yeah, just I find it a little bit hard to call sometimes.
Yeah.
Um, what about the effect on the kidneys from non-steroidals? What's the prostaglandins, protective prostaglandins do in the kidneys?
Uh, in the kidneys, I mean, it's to do with the perfusion, right? Like
Mm.
renal perfusion, I think it affects somehow.
Yeah, exactly right. Yeah, so the prostaglandins are responsible for regulating the glomerular pressure and afferent arterial pressure. So if we take away the protective effects, then the kidneys are really prone to or susceptible to hypoperfusion. So as soon as an animal's dehydrated or has low blood pressure and decreased renal perfusion, if you take away those mechanisms that like constrict the artery that's taking the blood out to maintain that glomerular pressure, then the kidneys can just essentially have their blood flow cut off, which results in acute renal failure, which we'll probably talk about more in our nephrotoxicity
Hmm.
section. Right? I
Yeah.
don't want to go
So
too
maybe in this case, like if you're suspicious of this, is this where that cystatin B you would use because it causes renal tubular injury? So worthwhile doing cystatin. I've never seen it being done or used it myself, but I know it's available. Is that a scenario where you would use that cystatin B?
right. Great idea. Yeah, perfect. And
It's just
it's
that it goes out, so by the time you get it, you already would have started treatment and things. So I don't really know how it's still clinically relevant because it's not an in-house test. So it's not like you know right away.
but it is nice. I mean, it will be amazing when it's a point of care test because it will be such a good marker when a patient's ingested a nephrotoxin, for example, known ingestion, and you sort of rather than have them hospitalized on fluids, you can just say, okay, let's just do this every 12 hours or something. So it's got really good potential, and it is nice to have that evidence that we need to support the kidneys even without the like azotemia developing. But yeah, it's not practical out of house, as you say. But yeah, it's a great idea to do one. Nice evidence. Um, so how does decreased blood flow or failure to regulate the renal blood flow impact? Like, how does it cause acute renal failure?
How does it cause kidney failure?
Mm.
Because if you have reduced blood flow, uh, your glomerular filtration rate will change, won't it? And then
Mhm.
that will then cause probably it'll cause hypoxia as well. Or there
Yeah,
will be some hypoxia.
yeah.
So then
So
the
that,
tubules will undergo degeneration.
yeah,
Then it may lead to, if there's degeneration, then there can be necrosis and
yeah,
inflammation.
yeah. So how do you feel about arts and crafts? Do you mind if I take a really long time to draw a picture? Because I think this is such an important concept when we're talking about renal injury.
No, no, please do.
All right.
Yeah.
Okay.
I love your art and craft. It's really good.
Me too. Uh, okay. So we go red. So we've got the arteriole coming into the glomerulus, and then it does this, and then it goes out of the glomerulus. And then we're going to draw the actual tubule, which is going to be yellow. Oh, my T's in the way.
I'm just seeing your name moving.
Is that all? Is that all you
Yeah.
can see? Yeah, right.
All I'm seeing is Anna Dengate moving.
And you can't see the pen?
Okay, now it's there. Now it's there. It's come.
Oh, okay. Oh, it's because I
But
was
there was a bit of a lag because all I saw was your name moving around.
Okay. So hopefully this is like a familiar structure to you, even with my arts and crafts.
Oh, good.
Okay. So here's the important part. So we've got this tubule is made up of basement membrane with epithelial cells lining it. So we've got blood coming in to the glomerulus, and then it pulls around at very specific, tightly regulated pressure. And the way that you regulate the pressure is by either letting more blood in or letting less blood out. So you can, if you don't have as much blood coming in, then you just close off this artery that comes out, or the artery, I think it's still an artery, coming out, so that we've got consistent glomerular pressure and we can maintain an acceptable glomerular filtration rate. So this whole tubule, all of those epithelial cells rely on, and all of the tissue around it, rely on this artery then continuing and blood flow in this artery being maintained and supplying blood to this whole tubule. So if you've got decreased blood flow in the glomerulus, or you've got failure to regulate blood flow in the glomerulus, and you've then got less blood flow either coming into the glomerulus or coming out of the glomerulus, then the tubule has its blood supply drop off. Those tubular cells die and they slough and they fall into the tubule. And then what do we see clinically if we were looking at the urine under a microscope?
Like the concentrating ability would change. Is that what you're thinking?
Actually, under the microscope, like if you're looking at
CAS. Sorry, like you mean CAS. Yeah.
Yeah, exactly. So those cells falling into the tubule and like lodging in there, blocking that tubule, will then also mean that the glomerulus will die, and the whole tubule, once the tubule gets blocked, the whole tubule is lost. So as soon as you get a decreased blood supply, you start losing tubules because those epithelial cells will start plugging them up. And I think this is just such an important concept, that this blood supply leads to this blood supply. So you might have less GFR, but you've also got loss of the whole nephron.
And this is what they mean by self-regulatory mechanism of the kidney, right? Like this is what you're talking, like if there's less blood flow in, then to maintain the pressure, then somehow the blood that's going out will be, you said, more?
So if you've got less, so say we've got a dehydrated dog and we've got less blood coming into the kidney here, this is going to dilate. This artery is going to dilate, so that as the blood's flowing past, that's going to become the path of least resistance to maintain blood flow in this glomerulus.
Yeah.
And then we're going to have, if we've then got so little blood flow coming in, that to maintain this pressure, we might constrict this artery to maintain that glomerular pressure.
Sure, yeah.
That's a compromise to tubular.
And that's how,
Yeah, exactly.
This is so good. Thank you. This is
it's such a good concept, right?
It's a very important concept, and I don't think textbooks do justice the way you've just it's just you've just made it very simple, but it makes total sense.
Well, we're going to get a little bit trickier when we start talking about AKI, as far as like where the tubules go and stuff like that. So I feel like if I close this, then I'll be able to reopen it. I'm going to do that for a while, and then we'll revisit this principle again. So that's what happens when you lose that regulation. All of a sudden, you're going to get way, like you might blast the glomerulus and like cause blockage of the actual blood vessel itself because it's caused damage to the glomerular arteriole, or you might not get enough blood flow coming through to then what's the word? Perfuse the tube. Sorry. Okay. What about hepatotoxicity with non-steroidals?
I think again, it's a dose. Can it be idiosyncratic? Because any drug can have idiosyncratic, so I'll put that in.
Yeah.
How common it is, to be honest, I don't really know. I don't think I've ever seen it.
Yeah, I think I've seen 2 cases. Both Labradors, which is weird, but Labradors are common in my area. So
And it's not so much toxicity, but we do know like some non-steroidals do induce ALP, right? So that's a different thing. That's not really toxicity. That's just induction.
No, actually, that's haven't noted. I can't remember reading about the ALP thing, but
This don't mean like don't some I think carprofen specifically does induce ALP.
I don't know. Yeah,
Yeah.
yeah,
I
I
have that
didn't.
in my head. I'll double check that.
Um, so essentially, like it can be either idiosyncratic or dose dependent. So at higher doses, we're more likely to get hepatocellular damage just directly, because the hepatocytes have got to work harder to detoxify and they're susceptible to those drugs sitting in the cells for too long, and the oxidant damage associated with that. The idiosyncratic reactions are usually immune mediated and not dose dependent. So that's a dog that you're never going to put them back on non-steroidals if they have a really big spike in that ALT with a very appropriate dose of non-steroidals. So that's non-steroidals. What specific treatment do we use with non-steroidal toxicity?
Misoprostol for like depends on the signs, right? Like so if you have gastric signs, then misoprostol is what we use.
Yeah.
I mean, first the decontamination fluids.
Yeah. Yeah.
Supportive.
And decontamination.
With misoprostol, I think it's a prostaglandin, so it helps with reestablishing the homeostasis in the gastric mucosa.
Exactly. Yeah. Perfect. So it's just essentially a synthetic prostaglandin. You're just replacing what the COX inhibition has taken away. So it works better if given as a preventative. So before we get gastrointestinal signs. So if you know that a patient's had an overdose, it's a great time to start the misoprostol. Less effective if we're using it reactively in reaction to an overdose or a side effect.
And then you would use like because you're worried about gastric ulceration, so sucralfate, proton pump inhibitors. So it's all supportive essentially.
Yeah, it's cool. Yeah. So I definitely see more like intestinal ulceration in dogs with non-steroidals. Like that's definitely reported is gastrointestinal ulceration as a side effect. And I'm assuming the mechanism's the same, but I haven't actually seen it specified because the prostaglandins in the distal intestine are going to be different from what's required in the stomach. So I don't really know what the mechanism is, but I just would treat those differently. So I think these patients, it's good to get some sort of localizing information. If you've got melena, gastrointestinal ulceration on steroidal use history, I like to know if it's gastric, because if it's gastric, I'll use omeprazole. If it's small intestinal, omeprazole actually makes the ulceration worse. So I like to know that before I am treating them, essentially. So helping to localize it.
So if it's in small, like if it's intestinal, what would you use then?
Sucralfate, supportive care.
But isn't sucralfate only for, I was thinking sucralfate is only for the stomach because it coats the ulcer but it can also be.
Yeah, so there's actually no evidence for sucralfate improving outcomes in gastric or esophageal or any disease, actually. But in theory, if it's activated in the gastric acid, then if it's moving through into the small intestine, it's not absorbed. It's like purely a superficial coating agent. Then theoretically, I feel like it's not going to do any harm if the owners aren't too overwhelmed with how many meds they're giving. Anecdotally, in humans, they say it is quite significant pain relief because of the coating it puts on ulceration. So in humans, they use the slurry when they've had tonsillectomies, when they've got like gastroesophageal reflux and stuff, because it's just that coating it provides some pain relief. So if that's a potential outcome, then I'm on board. But yeah, no evidence. Okay, let's do the tremorgenic toxins. Toxicities, this is actually a really interesting topic. Because we then get to talk about the mechanisms of how different stuff works. So if we've got tremors, it's a neurotoxin, right? Most of the time, sometimes muscle toxin, but typically a neurotoxin. So when you've got tremoring or increased activity, we can say that we've got increased excitation, and that can happen due to either a decrease of our inhibitory neurotransmitters or an increase in our excitatory neurotransmitters or the channels that they work on, kind of thing. So give me the name of an inhibitory neurotransmitter that acts centrally.
Inhibitory neurotransmitter, you're saying?
Yeah.
GABA.
GABA, great. It's the main one, exactly. So some of these neurotoxins actually decrease GABA or block GABA receptors or block the chloride channels that GABA works on. So GABA works to cause the inside of the cell to become more negative. So the neurotransmitters then have to work harder to cause an action potential in that cell. So if you block the chloride, which is the thing that goes into the cell to make it more negative, or anything that blocks that kind of pathway of GABA release, GABA receptor binding, and then chloride channel opening, any of those things, if you inhibit any of those things, you're going to have more excitatory cells or more reactive cells. And then what's an excitatory neurotransmitter?
Glutamate.
Glutathione. Yeah.
No, glutamate. I remember
Yes.
glutathione for now. Tomorrow it will be a different story, but right now I remember.
Right now, we've got it now. Yeah. So glutamate is the main excitatory one. And the effect of glutamate is to open up sodium channels or like increase positivity inside the cells and trigger action potentials. So if you've got anything along that pathway of increasing the release of glutamate, increasing the effect of glutamate at a receptor level, or increasing the receptivity or activity of those positive ion channels, you're going to increase that excitatory kind of pattern that we see with neurotoxicities. So tell me, and then I guess the other ones are like the serotonergic or dopaminergic neurotoxicities, but most of the neurotoxicities that are like serotonergic have other effects on glutamate and GABA as well. So there's a list as long as my arm of different neurotoxins that will cause tremors. What do you think is the most common one we see?
Oh, mycotoxins.
Yeah, mycotoxins. I think like garbage toxicity, moldy sandwiches, those sorts of things. Yeah. Hi, Simone. You've come just at the right time. We were just about to talk about kidney stuff, which is the thing that you wanted to cover last week, I think. Was that you?
Sorry, what did you say?
Sorry. You've come just in time. We're just about to cover nephrotoxins and kind of the approaches to fluid therapy and things. Was that you that requested that?
I don't know. I don't think so, but that's okay.
Maybe. Sorry, it just landed you in it. We're just talking about neurotoxins at the moment. So definitely mycotoxins or aflatoxins are the most common that we see. Snailbait, we don't see that very often anymore.
Yeah. No, snail bait is like you do see emergency pretty not common, but it's not uncommon.
Yeah. So essentially all of those will cause excitation and tremors. Therapeutically, what can you do to decrease excitation in the central nervous system?
Give them the methcarbamol.
Yeah. Is that central? Does that act centrally?
Oh, don't know. We'll have to look that up. I'm not sure if that's central.
I've got this impression that actually that acts peripherally. So it's actually at the level of the the neuromuscular junction.
Which may be correct.
Yeah, so I think it doesn't actually decrease the effect. So it's not because you wouldn't use methocarbamol in a seizuring patient, would you?
No, you would use it on a tremoring patient. So I think you're right.
Yeah. So what about centrally? How do you decrease action potential firing centrally?
By using benzodiazepines, like they're the most commonly used.
Yeah. And how do benzos work?
GABA receptor.
They do what to the GABA receptor?
They activate it or do they inhibit it? I don't know.
They activate it. So yeah, we were just talking about, so GABA is the main inhibitory neurotransmitter.
Yeah.
So a lot of these neurotoxins either decrease release of GABA, block the receptors of GABA, or block the chloride channels, which the GABA then opens up to make the cell become more negative and refractive to action potential. So any of those points on the pathway, we can kind of target with our like antidote sort of thing. So we increase GABA activity in these dogs that have got too much excitatory stimulation. So GABA potentiators.
Potentiators.
Like benzodiazepine. What's another one we use quite commonly in seizuring patients?
Phenobarbital.
Yeah, exactly. Yeah, similar mechanism of action. The effect on the chloride channels in the brain. Good. So, and methocarbamol is really the only other thing. Obviously, if they're in status, we're going to follow the status consensus guidelines, obviously. So propofol infusion if required. Okay. So let's talk. We've just got 10 minutes to go. Let's go to this nephrotoxicity discussion.
Oh, I forgot the different time zone. So I'm in Adelaide.
Why are you in Adelaide?
I'm on externship with radiology.
Ah, that's fun. Yes, sorry, you must have thought we were really
Don't worry, probably fine.
Well, externship is fun. You don't have to write your notes. Like
good.
you can just sit and relax.
A radiation vacation is what it's been called, and it's absolutely fitting the bill.
Love it.
Oh, and I met Alex, who I believe knows Anna Father.
Ah, I love Alex. How's she
Very
doing?
small. It's a very small world. Yes, she's good.
She's good. Good. Excellent. Yeah, Alex's husband was my resident.
Yeah, Josh, which I was like, we talking about the same Josh? Yes, we were. Anyway.
Yes, Josh.
How many medicine residents can they be called Josh who know you well? Yeah. We worked it out eventually. Yeah.
Okay, so the reason I wanted to talk about nephrotoxins, or the reason whoever it was that requested we talk about nephrotoxins wanted to talk about it, is because there's a little bit of controversy over how we manage a patient that's had no exposure to a nephrotoxin. Do we hospitalize them, put them on fluids, diurese them, and is that protective against development of renal injury? What do you guys think? Because it's controversial. There's no right or wrong.
I think, I mean, if my thought is if you're doing it, the new literature is saying that you should do it when there's evidence of actual renal damage. So don't do it prophylactically, but do it when there's actual evidence. A, B, the fluid rates, because in the past we used to all, like I've done too when I just graduated, like 5 times maintenance and all that. That's totally out of the you just sort of, if the animal is hypovolemic, you treat the hypovolemia, but then after that you should just put them on maintenance rates. And then if they're critical, then there's a different critical illness maintenance rate, which is actually lower than your regular maintenance rate. So this whole overflooding patients with fluids, it actually increases the interstitial edema around. It's actually detrimental.
Yeah,
absolutely.
And I have some discussions with everybody who works with me about this.
I think it's changed. So the recommendations in the last 20 years are completely the opposite. So what were you guys, like first practice you worked in, had a patient with acute renal failure, what fluids do you put in the one?
Like the kind or the rate? What do you like? Kind. Crystalloids typically, depending on like what their electrolyte sort of, and what else is happening as well, like comorbidities. I would look into that as well.
Yeah. So I was taught like 0.9% saline, like without a doubt, you don't deviate from that. This is what we treat acute renal failure with. And the evidence for that now is so bad, actually, like it's actually completely flipped. But there was very strong evidence for that then. Like this is a very evidence-based clinician who taught me that that's what you must do. So do you guys know the reason behind sodium chloride not being a great choice?
Because I am thinking because there's metabolic acidosis already, and sodium chloride will worsen the acidosis.
Very acidic. Yeah,
They
exactly.
often get hypernatremic if you've got one.
Exactly right. So what happens in hypernatremia?
After a point, it affects your CNS and causes.
Sorry. I'm with regards to like glomerular filtration and like pressure on the kidneys kind of thing.
It'll worsen because sodium will pull water, so you'll actually cause more edema. Is that even there?
Yeah, so what it actually does is causes PU, right? Which is like the theory behind using sodium chloride when we first started using it was we're flushing the kidneys, like we're sucking the sodium and fluid through those tubules and it's going through so fast and it's like going to flush out any casts and stop them from getting obstructed and stuff like that. It just doesn't work like that. And if you are really early on in like renal injury and we can't detect that clinically, like if you've started to lose nephrons, block nephrons, and all of a sudden you've got decreased ability to, like the GFR is dropping on a global scale, each nephron then has to process that much more, which means they can't then reabsorb anything, which worsens the acidosis, and you end up with like delivering too much fluid and you end up with edema, which then decreases tubular perfusion, which blocks more tubules and blah, blah, blah. So it goes on like that. So sodium sucks water in. What else does it take with it?
All right.
All right, exactly. What happens when you I think I'm just going to tell you this and I'm going to get my arts and crafts back up again. So Simone, before we were doing arts and crafts on like how the renal blood flow works.
Oh yeah.
We've got I get so confused between afferent and efferent, but we've got the arteriole that comes into the glomerulus here, and then it goes wiggle, 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 and then it comes out of the glomerulus, and that is the blood supply to the whole rest of the tubule. It's a really important concept because what we were talking about this in the context of non-steroidal toxicity, where we lose the prostaglandins, which contribute to regulating that blood pressure. So if we've got a dehydrated patient or a hypovolemic or what's low blood pressure called?
Hypotensive.
Patient, we've got decreased blood flow in arteriole. So then normally what would happen is that arteriole would dilate so that then there's less resistance for blood flow to come into the glomerulus to maintain that glomerular filtration pressure. And then if we can't maintain that by affecting the in arteriole, we're going to constrict the out arteriole to maintain that and make sure that urine is continually being produced and there's flow in those tubules. Because what happens when flow in the tubule stops?
They will die. Like, is that what you're asking?
They get plugged. Yeah, so they just get blocked up. And then once they're blocked up, if there's nothing moving through them, then they die, and they're absolutely useless. So the body wants to prioritize fluid moving through these tubules. So if we get to the point where we have to constrict this arteriole, we're actually compromising the blood supply to all of those epithelial cells. That's then going to result in cell death, ultimately, if that blood loss, the perfusion loss gets to that point. Those tubule cells are going to fall into the lumen, and tubule is going to block and it's going to die anyway. So if we get to the point of needing to regulate at this level, we're really compromised here. So what actually happens when you give sodium chloride is you dump sodium into the tubule, you dump chloride and water into the tubule, and we're flowing really fast. It sounds good, right? Less likely to get blocked if you're flowing really fast. But what actually happens is this distal convoluted tubule, this is not anatomically correct, just for the record. This tubule actually flows in between the macula densa.
Yeah.
So it actually flows up here again. And if you've got high chloride in the macula densa, you actually activate your RAS system and cause constriction of that even further locally. So you get this local renin production and vasoconstriction locally, which means that your perfusion goes down even further. So high sodium fluids are not indicated because they will worsen edema, create polyuria, which actually makes maintaining hydration harder, and also alter perfusion of the kidneys and potentially contribute to nephron loss. Okay. What is this so busy today? So then if we are going to give them IV fluids, we've kind of agreed that what we're trying to do is maintain that perfusion, right? We're just trying to get that circulation, keep the flow in the tubules and maintain renal perfusion. What happens if they become oliguric and we haven't detected that yet? Or if their ability to like excrete fluid drops and we don't detect that clinically? So if we overload them with fluid, even if it's the right fluid.
Same thing will happen, won't it? Like,
Yeah, exactly the same thing. Yeah. So we're going to get edema of the interstitial tissue, which is then going to push on both the tubule and the vessel and decrease renal perfusion. And then we're going to get nephron loss again. So you can actually do quite a lot of harm with over perfusing. So you definitely don't want to go too hard on the fluids. And as their renal function drops, you need to know as soon as it drops so you can decrease your fluid rate so you're not contributing to that nephron loss. So in my mind, my priority is, because I don't think I can detect that clinically. Like we just, you monitor ins and outs and it's so invasive, so intrusive. But my priority is always like maintain them feeling well enough to hydrate themselves because they're better at regulating that than we are. So my priority is always anti-nausea medication, always making sure that there's appetizing fluid sources available and maintaining gastrointestinal absorption of fluid because that's self-regulating. So that's usually my approach. And then Pooja raised the idea of doing the cystatin B and screening for casts as the two things that we use to say, okay, well, we're getting to the point now where there's some active renal injury. We really need to keep a closer eye on this. So those patients that have ingested a nephrotoxin and we're not sure if they're going to get toxicity, that would be my approach, is to monitor for those biomarkers or cellular evidence of renal injury rather than try and do the job for them.
but like, this is all good in theory, but in practicality, a bit hard in the sense you send the animal home because casts, we know that you have to look at the urine like sort of straight away. Otherwise, casts you can get false sort of results. Now, by the time the owner comes in, it's not really unless then you're doing a cysto every time. And that's not like practically, I don't know how practical this is.
Yeah.
All good in theory, but
Right.
I don't know how you can actually practically do this.
Yeah. So I guess that relies so much on the owners being able to essentially nurse them full time. Otherwise, they need to be in hospital.
Yeah.
And then need to manage their anxiety levels, which will contribute to them not hydrating themselves appropriately.
Yeah, it's such a, There's the other option is I was thinking maybe we don't put them on fluids, but still hospitalize them. But then that's a very good point you're raising, that if they are stressed and they don't drink, then we could actually tip them over.
Yeah, exactly. We might cause or contribute to the nephron loss. It's an impossible situation. And it's going to be quite patient dependent. And I think this is why it's controversial, because there are patients that neither one of those options is good. And we're just going to have to compromise and do the best we can. But if I'm putting them on fluids, I want to be monitoring ins and outs really closely and looking at casts every 6 hours and SDMA, all those early markers that we have.
But definitely no 5 times 5 times maintenance, because that still happens and it's always an argument with colleagues because it's like.
And this is such a long story to explain, right? Like when you're trying to say to people like, I'm going in and doing like a half-hour ultrasound and I'm like drawing out the graphs, renal tubules and perfusion and stuff like that. And they're like, well, so I shouldn't have them on 10 times? No. All right, we better wrap up. Sorry about the time zone.
Oh, totally my fault.
No, I'm glad that you could make it in the end.
Yeah. Have fun on your externship.
Thank you.
So,
Yeah, learn heaps. It's fun.
That's good.
right. See you guys.
You have a
Bye.
good day,
Thanks,
everybody.
Anna. See you, Pooja.
Bye. Thank you.